I'll be discussing the concept of sensory perception, and the exemplar is going to be eye injuries. These are the student learning outcomes which you'll be able to find on the Canvas site under the Sensory Perception tab. This picture shows the anatomy of the eye and the different layers. The retina is the innermost layer of the eye, and it is attached to the choroid layer, and this is going to be an important layer to discuss when we talk about retinal detachments. That layer is the blood supply for the eye. Next, we're going to talk about a corneal abrasion. And a corneal abrasion is a superficial abrasion or a scratch on the surface of the cornea. This occurs when the cornea comes into direct contact with a sharp object, such as a fingernail, or if a foreign body flies into the eye. Symptoms include pain, redness, photophobia, blurred vision, tearing, and the sensation that something is in the eye. Corneal abrasions are very painful, and the reason is because there are hundreds more pain receptors in the cornea than in the skin. A physician can diagnose a corneal abrasion by placing a drop of fluorescein dye into the eye. The dye will cause the abrasion to turn green when viewed under a black light, which is called a Woods lamp. Treatment for a corneal abrasion includes antibiotic eye drops or ointment to prevent infection. Steroid eye drops are going to be given to decrease inflammation. Acetaminophen and ibuprofen can be taken for pain. The patient can wear a patch to decrease blinking, which could actually make the abrasion worse. Cycloplegic drugs can be prescribed to paralyze the ciliary muscles of the eye and keep the pupil dilated. The patient should be instructed not to rub their eyes or wear contact lens or makeup until the abrasion heals. Superficial corneal abrasions usually heal within 3 days. Deep abrasions may take longer and result in scarring. A chemical injury of the eye presents a genuine acute emergency situation that requires immediate evaluation and treatment. The goal of therapy for a chemical burn is to restore corneal clarity, normalize the ocular surface, and prevent optic nerve damage. Acids tend to be less abrasive because they denature, coagulate, and precipitate corneal proteins on contact, which creates a barrier that prevents deeper penetration of the acid into the tissue of the eye. Alkali chemicals penetrate cell membranes, denature the collagen matrix of the cornea, and facilitate further chemical penetration. Affected tissue can undergo liquefaction, necrosis, and a cascade of other damage. Potent alkalis can reach the anterior chamber in less than 15 seconds, causing destruction of tissue in the cornea as well as in the anterior chamber. Penetration can continue to occur long after the initial exposure takes place and could result in glaucoma. Initial treatment of any chemical burn should begin immediately at the time and place of the injury. The affected eye should be irrigated copiously with water at the injury site and throughout transport to the hospital. When the patient gets to a hospital, then they will likely use Morgan lenses to irrigate the eyes. There is a link to a video on your student learning outcomes, and it is related to the Morgan lens irrigation system. You should watch that video and take notes on it because you may see it again on a test. So the irrigation should continue at the hospital until the pH of the ocular surface has normalized to 7.0. After it normalizes, the pH should be rechecked with pH strips at 15 and 30-minute intervals, just to make sure that there hasn't been a change in the normal pH level. Once pH has been neutralized reliably, a complete ophthalmic examination is going to be required to characterize the extent of the injury and plan further treatment. Intraocular pressure should be checked because serious chemical burns can greatly increase or lower intraocular pressure. Even if it appears that one eye is injured, the other eye should be examined carefully, including checking the pH in order to confirm that both eyes have not been affected. For a grade 1 injury, which is a minor ocular injury, the patient will receive a mild topical antibiotic ointment such as bacitracin or erythromycin. The patient will also be prescribed preservative-free artificial tears to keep the eyes moist. A topical steroid like prednisone should be applied 4 times a day for approximately 1 week. This is given to control inflammation and facilitate the re-epithelialization of the eye tissue. For comfort, a topical cycloplegic agent can be instilled into the eye 3 times a day. Patients with grade 1 injury should be followed at least every other day until the entire ocular surface has healed. They should also continue to be followed long-term to assess for dry eye and other issues. For severe ocular chemical burns, hourly application of topical prednisolone is recommended while the patient is awake for the first 7 to 10 days in order to control inflammation. A long-acting cycloplegic like scopolamine or atropine should be used to comfort along with oral pain medication. Initially, patients with severe chemical injuries should be seen daily to assess epithelial healing, measure intraocular pressure, and monitor for progressive corneal melting. Frequent follow-up is essential until the epithelium has become intact. Necrotic corneal and/or conjunctival epithelium is going to need to be surgically debrided. If this occurs, the patient will receive topical anesthesia on the eyes. A corneal transplant may be required to restore vision once the ocular surface has stabilized. Management of glaucoma remains an important issue following any type of chemical injury. This is a picture of a hyphema. A hyphema is the pooling or collection of blood in the anterior chamber of the eye, which is the space between the cornea and the iris. A hyphema is usually the result of blunt trauma to the eye that tears the iris or the pupil. The symptoms are typically blurred vision and ocular distortion. Pain, headache, and photophobia often occur if the hyphema has been caused because of trauma. Treatment includes wearing an eye shield, limiting activity, and keeping the head of the bed elevated at 45 degrees. Maintaining head elevation of at least 45 degrees is going to allow the hyphema to settle inferiorly within the anterior chamber and avoid central visual obstruction. Pain control for patients with a hyphema should not include aspirin-containing products or NSAIDs, as these can increase the risk for further bleeding. Topical corticosteroids or systemic steroids may be used in severe cases. They're often given to reduce associated inflammation, but you need to monitor the patient for rebleeding. Topical cycloplegic agents are also useful for patients with significant ciliary spasms or photophobia. An orbital fracture occurs when there's a break in one of the bones surrounding the eyeball, also called the orbit or the eye socket. Usually, this kind of injury is caused by blunt force trauma when something hits the eye very hard. A blowout fracture is a break in the floor or inner wall of the orbit or eye socket. A crack in the very thin bone that makes up the walls of the orbit can pinch muscles and other structures around the eye, keeping the eyeball from moving properly. Getting hit in the eye with a baseball or a fist can often cause a blowout fracture. Symptoms of a blowout fracture can include blurred, decreased, or double vision, black and blue bruising around the eyes, swelling to the forehead or the cheek, swollen skin under the eye, numbness to the injured side of the face, blood in the sclera, difficulty moving the eye to look left, right, up, or down, a flattened cheek, intense cheek pain when opening the mouth, or bulging or sunken eyeballs. An ophthalmologist will examine the eye and surrounding area. The patient will also receive facial x-rays as well as a CT. Treatment for an orbital fracture is an immediate ice pack to the eye to decrease swelling and decrease pain, as well as antibiotics and decongestants. Teaching should include instructing the patient to avoid blowing their nose while they're healing. A retinal detachment occurs when the retina, which is a light-sensitive layer of tissue in the back of the eye, is pulled away from the choroid layer of the eye, which is the blood source for eye tissue. The symptoms of a retinal detachment occur suddenly. If the retinal detachment isn't treated right away, more of the retina can continue to detach, which increases the risk of permanent vision loss and or blindness. Patients with a retinal detachment may suddenly see flashes of lights in one or both eyes, a dark shadow or curtain on the sides or in the middle of their field of vision. Patients at risk for detached retina include those with a history of a prior detached retina, eye trauma, cataract surgery, diabetic retinopathy, and extreme nearsightedness or myopia, especially if it's degenerative myopia. Surgery is often used to repair a retinal detachment, preferably within days of the diagnosis. The type of treatment depends on the severity of the detachment. Patients with retinal detachments need to remain calm so as not to increase their intraocular pressure. That's why the nurse should only allow supportive and calm visitors at the bedside. Activity restrictions for a patient after retinal detachment surgery need to include no bending, straining, and they should be wearing an eye shield. And the importance of follow-up and immediate care after a retinal detachment or retinal surgery is very important, especially if they start to exhibit symptoms that the retinal detachment is reoccurring. I put these slides in here to show you the visual field of someone with different types of visual disturbances so you can understand. So this picture right here is a retinal detachment, and these black specks are the floaters, and this black part right here is what they describe as the wall or the curtain that starts to come over the visual field. They don't always occur in this spot. It could include anywhere over here or anywhere over here. But I just wanted to show you what this looks like. So when a patient has glaucoma, which I know we're not talking about glaucoma, but I wanted you to understand that when somebody has glaucoma, their field of vision, let me go back to this, their field of vision is impaired all around the periphery, but it's clear in the middle. Whereas somebody who has cataracts, their entire field of vision is blurred. And somebody with diabetic retinopathy, this is clear vision, and somebody with diabetic retinopathy, they not only have blurred vision, but they have black blotches of in their field of vision. Penetrating eye trauma. Penetrating eye trauma is going to require a surgical intervention to remove whatever has penetrated the eye, whatever foreign object has penetrated the eye. You never want to pull any foreign body that has gone into the eye out. That's a surgical intervention. The patient's going to need pain relief and protection from further injury. So what they actually say you should do is you should place some type of cup over a paper cup or styrofoam cup or something like that, plastic cup, over the patient's eye so that it protects them from anything else coming into their eye. The eye is going to naturally remain open, but as they're going to the hospital, you should try to cover the eye so that they don't get any further damage. And like I said, obviously, do not attempt to remove the object. Ultraviolet keratitis. Other names for this are welder's burn or snow blindness. And this is actually a radiation burn that occurs when ultraviolet light absorbed by the cornea cause damage to corneal epithelial cells. The damage produces keratitis, conjunctivitis, or both. The effects are usually cumulative and may take up to 2 days before the patient starts to experience symptoms. Assessment findings include severe pain and photophobia, conjunctival irritation or tearing, and decreased visual acuity. Treatment for ultraviolet keratitis includes topical ophthalmic antibiotics, cycloplegics, and oral analgesics. So that is why it's so important when you're going on the water or in the snow, because the light reflects off of the water and the snow, and continued exposure to that can cause ultraviolet keratitis. So when you're skiing, water skiing, you want to wear sunglasses or some type of goggle, as well as when you're snow skiing, and when you're in a tanning bed also. That's why they make you wear goggles, so that you don't burn your corneas. Diagnostic tests for patients who have eye trauma are going to include facial x-rays, CT scans, and ultrasounds. And the ultrasound is usually to check the blood flow in the eye. Pharmacological therapy, I already talked about cycloplegics and all of that. Mydriatics are medications used to dilate the pupil and relax the focusing muscles of the eye. This is going to cause blurred vision. Cycloplegic drugs paralyze the ciliary muscles of the eye to keep the pupil open longer. Atropine is a cycloplegic. Ketorolac eye drops, which are an NSAID, are often used for pain relief and decreased inflammation and swelling. When a patient has eye trauma, it's important to try to get an eye exam to see what their visual acuity is. So historically, the Snellen eye chart is used for this in adults. The patient is going to stand 20 feet away from the eye chart, and they're going to cover one eye and try to read the eye chart. And these are the different scores. If you're standing 20 feet away and you can read this line, line number 8, then you're said to have 20/20 vision. And when you do an eye examination, and nurses can do eye examinations, you're going to check both eyes. So you're going to have the patient cover one eye and try to read, and you'll write that score down for that eye, and then you'll have them cover the other eye and write down that score for so you're going to get 2 scores, 1 score for each eye. We talked about, with a corneal abrasion, the fluorescein strips, and these are going to be kept in your Pyxis or something, and you can you're going to put a little drop of that, and it will go into the eye. It'll absorb into the mucosa. turn it orange, and then when the doctor does the eye examination and shines the black light in their eye, they'll be able to see a corneal abrasion. The last thing I want to talk about is nutrition for eye health. Patients who, or people who have any kind of eye issues should be ingesting these types of foods. So, foods that are rich in vitamin A, like carrots, beef liver, chicken liver, pumpkin, and milk, help to nourish and strengthen the retina. Foods that are rich in vitamin C, citrus, green leafy vegetables, and peppers, they're also good for eye nutrition. Omega-3 fatty acids, which fish, seeds, and nuts have a lot of omega-3 fatty acids. Zinc, eggs, beef, and salmon have zinc as well as omega-3 fatty acids too. Foods that are rich in beta-carotene, orange things like carrots, sweet potatoes, or dark green leafy vegetables. And eggs. Eggs are a great source of both vitamin C, E, and zinc. So this is the end of my discussion on eye trauma. And if you have any questions, you can email me at cwiggi@dcc